Mai e te rangi ki te whenua, mina me katoa. Kia wana nui, haumi e, hui e, tai ki e. We'd also like to acknowledge those that are joining us virtually. So hi, wherever you are. First up we have Melanie Poxton. Hopefully I haven't butchered that name. Registered nurse for more than 35 years. And Melanie currently works for the Department of Health in Queensland in the Office of Research and Innovation and is based in Townsville University Hospital.
Hello. Oh, got to move my slides on. Thank you. So, thank you. It's a pleasure to come and speak to you this morning. So, I would like to pay my respects to the custodians on the land on that we're meeting today and where we live and work. In my case, I live in Queensland in the tropics, hence I'm keeping my jacket on. I'll just go back. I did actually tape somebody speaking Maori and practice really hard, but decided to not give it a go. I haven't got the courage for it. But I enjoyed the session this morning, having to practice a little bit. So, why do we need to do it? Teletrials. Just for a show of hands, could everybody tell me, show me in the room, everybody here has done clinical trials, right? Yep. Has anybody done teletrials? Oh, I know the ones on the panel have. Thank you. That's great. So, why do we need to do it? Obviously, we've talked about health inequity this morning. I'll talk to you a little bit about the level of disparity that I actually found when I went out and mapped the services in Queensland. And probably, you know, some of it would be similar to your own experiences, both in Australia and New Zealand, I'm suspecting. So, Australians, you know, in rural, regional and remote areas have shorter lives. They have higher levels of disease and injury, poorer access to and the use of health services. They face barriers when they take part in clinical trials. There's cultural differences, the geographical isolation, there's much, much more. That's just from the Commonwealth. When you go out and map the services, there's so much more. So the teletrial model itself, the Australian teletrial model was published in September 2016 from the Clinical Oncology Society of Australia, COSA. And in 2017, I was a trials manager of cancer in Townsville University Hospital. And I was tasked with being one of 2 pilot sites that had to implement this model. So we did all of that work, and all the documents are on Medicines Australia published today. But since then, we got the Commonwealth funding for implementing teletrials, and across the country in Australia, it's just short of 130 million across the jurisdictions, including all the states and territories, and you'll hear about some of the people that are doing things in border oncology and revitalised programs. So supporting pillars are establishment of RCCCs. The regional clinical trial coordinating centres are actually pivotal to the success of the model. Education and workforce, capacity building, and then having a look at actually capability first. What's the capability and then what's the capacity? Because the rural, regional and remote clinicians already have a very demanding workload. So finding how you can support them when you're actually asking them to do now a little bit more still. Equipment and logistical resourcing that we've been doing. Teletrial recruitment boosting. There is a program in Australia that does give sites additional funding. And policy harmonisation, which sits with the National Office. So the way that it works, in the team that I'm working in is 6 jurisdictions. So that's Victoria, Tasmania, NT, SA, WA and Queensland. And the National Office actually sits in the same office as I do, in the Office of Research and Innovation in Queensland. And that's because they're the custodians of the Commonwealth funding. And we have had to really do a lot of work in the governance space because sponsors want regulatory reform. You know how slow it can be to get a trial up and running. Can't keep allowing that to happen. There's a lot of work that's happened. And then there is some formal evaluation and impact assessment from JCU in Townsville and QUT in Queensland in Brisbane. So for anyone who's done clinical trials, I just want to dispel a myth right up front. Teletrials is not hard. Neither is it rocket science. There are just 4 key documents that you need, additional to what you normally know. So a supervision plan, which is, there's only ever one principal investigator in a cluster, so a primary site with 1 or 2 satellites or more, and the PI oversights all of the activity at each of the satellite sites. There's a subcontract because the sponsor only has the main CTRA with the primary site. So the subcontract is the means that we bind the primary site to each of its satellite sites. Wording for protocol development, if you're writing a protocol new, we do have a paragraph that you can insert. It's nice because ethics like to have a reference and governance like to have a reference point. And then there's a standalone Teletrial consent form. We did do additional wording for the master, but we found that for some sponsors, they didn't want that. And also, it places a burden because if you then make that master amended for everyone, you have to then reconsent everyone to that consent form. So in reducing the burden for the patient, we only have to consent those who are actually going to go on a Teletrial. I'm going to go through 20 minutes. I had a half an hour last time and I didn't have enough time, so let me go quickly. We're going to develop clinical trial workforce capacity and capability. It's based on network connected care. And honestly, if I get a chance, I'm going to talk about how this model transcends its intent. So it helps sponsors and investigators expand across broad clinical trials because it basically was a lot of the work's been done in oncology, you would know that, but there is a real move now to other disciplines, and I can talk to Queensland and some of what's been happening, which is pretty exciting. We are providing some funding. I think I said to my colleague earlier, Narelle, I think I just sent 120,000 out to the sites in this reporting period. Why become involved? Care closer to home we heard about, reduced travel, improves data and diversity. So for sponsors, they want inclusion, they want diversity in the trials, we can give them that. Developing workforce, I'm going to have to try and skip. Right, let's go. IQVIA also did some work, produced a report telling us why telemedicine and patient diversity and the greater features of clinical trials are coming in the future. Basically, the teletrial model is going to be required for anybody that works in cancer. We've basically done a lot of the chemotherapy, a lot of the immunotherapy. We're into precision medicine, targeted genetics of the patient population, and that requires a wider net to get the patient numbers on the trials. And I've done quite a bit of modelling on this recently with DCT and teletrial hybrid modelling. So what are we doing? We're working with statewide ethics and governance, making the approval much more efficient. There's a national meeting tomorrow in Adelaide with all the RCCCs, of which I'm not going because I'm here. So it was my preference to come to AGITG. And we're developing remote health services to be able to work in the clinical trial space. And it's not a one-stop shop. You can be involved in a clinical trial in a remote community if your patient can only have 3 visits back closer to home. That's fine. It's 3 visits. The patient doesn't have to travel. And for sponsors, just say to them, you're more likely to get patients on your trial if they can have care closer to home when they can. They will travel if they have to. But if you want overall survival and progression-free survival data, you'll keep patients longer if you let them have the follow-up care and the maintenance care closer to home. It's to me, it's like a no-brainer. I don't know if you say that here, but I say it. Okay. Right, let's move on. This is the site capability. I don't think we've got any sponsors in the room, but the sponsors love this slide. So across the top, 16 hospital and health services, which are all the health services in Queensland. Down the side, the disciplines, and then where have they done clinical trial or teletrial. So all the green is clinical trial, all the green in the second column in TT is teletrial. And it's very clear to see that oncology leads the way by far. I was going to do a poll, but I won't have time. But I would like you to think at some point, how would you work together to form clusters? Because that's really important. The people in this room are key. The clinical research coordinators, and you having the vision to understand that it just needs logistical planning to make this work. That's all it needs. And a vision that you can do it. So for me, I presented at the Brisbane Cancer Conference last year. What I said was then, start with, when you sat with a patient in a clinic, ask yourself, before you jump to give them standard of care treatment, which might not have optimal health outcomes, is there a clinical trial in this country? Because if there is, can you please have a look and stop for 2 days before giving them a treatment that's not going to target what they need? Because as I spoke, we got nominated for a research award just recently, so I went out for a nice dinner. And so I spoke to a board member. He was male, so I said, right, okay, he's an accountant. Let me explain something. Why are you going to spend money on 8 lines of treatment for ovarian cancer when none of it targets the very thing that's driving the cancer? Here's the thing. You're a bean counter. I'm not. I'm a clinician. This is a cost saving for you. Let's find what's driving the patient's cancer in the beginning and let's treat that, because that's a much more sensible approach. So we need to be clever with our messaging and give them the right messaging, because we can actually save money over time. It's not about money for me. It will never be about money. But for people who count the money, it's about money. So we have to talk their language so that we can get what we need. So that's what I want everyone to do. And as I say, care closer to home where possible. So if they have to travel to the primary site, and I'm doing quite a bit of modelling on specialised services where the only place a person can go is into Brisbane Metro for a specific oncology treatment. But every person in the state can have access to the trial because they're going to Brisbane anyway for that treatment. So how's about making the rest of the trial available closer to home so that they can actually choose the option? Because otherwise, you're actually actively discriminating against them to not have access, and I have an ethical problem with that. This is the QRCCC, led by Professor Sabe, who Craig, who's going to speak later, knows very well. He's our clinical director, works 0.25 for us, and he's kind of known as the guru of telehealth. He did all the telehealth, teleoncology, telechemo models for all of you that have worked or know about that. I'm the Assistant Director of Nursing of the Queensland Implementation statewide team. We have startup specialists. I've just recently brought in an ethics and governance remote support for the 4 remote HHSs and some additional CRCs as well. So, and the other thing that we've done is I've put a 0.5 CRC for 2 years in every HHS, in all 16 HHSs in Queensland, to facilitate this model. I don't know what I'm doing for time, so if somebody can tell me, I can go on to something else if I've done well. Have I got 8.5 minutes left? Oh, that's good. All right. Hey? Now I can relax now. I got through the main part. So the RCCCs in your state and territory, I would say, are your first point of contact. Go to them. Why? Because they're fully employed to enable the infrastructure. You don't pay for them. So people come to me, I start up a trial right from the get-go. We'll do all the ethics and governance with the sponsor as well. So I always say, wear 3 hats: the hat of the sponsor, the hat of the primary site, the hats of the satellite sites. Wear them all. We can do all the ethics and governance. Busy clinicians don't need to do it. We can facilitate the whole process, but we also take them on a journey. So if they've not done it before and you're building capability out at a remote or rural or smaller regional centre, if they've got time, we get them on teams and we walk them through. So in Queensland and Victoria, if I don't know what the other systems use, we use something called Ethical Review Manager for all our submissions. So we'll get them on teams. I've done cheat sheets for them so that they know what to fill in each section. Obviously got to tailor it to the trial, but it just makes things so much easier. So the RCCCs, we share what we're doing in Queensland with all the other RCCCs across the country, including New South Wales and ACT. So we're happy to share with anyone because it's for patients. It's not about who's best at this. Honestly, could not care who's best at this. This is about patients having access. And as a cancer nurse, when you sit with them and there's nothing really to offer, it's soul destroying. So I was actually writing, just aside from that, I was writing something to try and get, I guess, increased engagement with clinicians, so the uptake. So I think if we can let them know, so I was really interested in what Liam had to say about a website, because the National Office has an Australian Teletrial Programme website. If you don't know, have a look at it. But I think, you know, based on what I've learned here this morning, I think we can improve it. Because you're right, when you go to a website, if it's not engaging, I'm a very visual person. I'm not looking in that space very long at all. So I think I've learned something, I took lots of notes, and we can improve that space. So there's a few things. I want to try and look at where can we put all the activity of clinical trials and teletrials and the cluster activity. Should we sit it in the ATP website, or is there another place that it fits better? Anyone can access that site, so that could apply to New Zealand as well. But I want people to be able to see who's engaged in teletrials clusters, who's doing this work, who can you go to. The other thing that's a more recent development, as I kind of mentioned, was the decentralised clinical trials, which, as we know, all the sponsors have a big momentum towards post-COVID. So looking at the DCT teletrial hybrid modelling is something I've been doing, and I tend to like to just put things on a one-pager. So done some statewide planning for where those services are only offered in the metropolitan areas, making sure we can get access for everyone. If you can put it on a page and show that kind of schematic or whatever you want to call it, that you can actually see what you're going to do, that is helpful as well. So yeah, RCCC's first point of contact for you all. If you don't know who they are on the ATP website, I've just asked for it to be moved, because taking the point over there, you go into the website, you click along, under sponsors, right down at the bottom is the RCCC's contact. I said, we are integral to this model. We are implementing, we are talking to everyone around the country. Why are we at the bottom of a list that you wouldn't, I didn't even know to find myself in the RCCC under the sponsors. So we can just do something simple and move that up as a tab on the top. So if you go to the ATP website, go to RCCC's, you're going to get whichever contact you need. The other thing we're doing, we're grant writing with people. So Griffith University and some other universities I've been working with. Protocol development, I do work with the VCCC and also the Australian Clinical Trial Education Centre. So in Australia, there's free training for everyone, paid for by the RCCC's through that programme, including GCP, is free on there as well. So we've been doing some protocol module development. So that'll be coming soon as well. So writing your own protocols. And the other thing is, just recently written a protocol for a pilot study, just 10 patients in diabetes, but hopefully it's going to lead on to a phase 3 study. So having that ability to write your own protocols, also you can have internal clusters within your own health service or your own district. So just taking an example, in Townsville, we've got a town to the north, 100 k's to the North Ingham, to the south, Home Hill and Ayr, another 100 k's. So they can be part of an internal cluster. The thing we need to do is go to ethics and say to the sponsor, on your ethics notification, don't just put Townsville University Hospital, put Townsville Hospital and Health Service. Now you've just captured all the people within that region, and then we can facilitate it. We can open maybe a primary site and a satellite site, even just the primary site in the rare cancer stuff. And then when you identify a patient who needs access, let them go to Townsville for a visit or two. We hope to turn around governance if we've got ethics within 2 weeks. So that patient will probably only visit for one cycle, and then they can have the rest of the care closer to home if it's appropriate. That's a real enabling model. So I'm hoping that, and on one of the rare cancers that I'm working on at the moment with a major sponsor is a phase 1 study. So using this modelling, I'm hoping that we're going to be able to demonstrate through data that instead of taking 2 years to recruit that 19, 20 patients in that ultra-rare space, with this modelling, connect and network care, we could get those rare patients hopefully recruited in six months. So what's the cost saving to sponsors if all your recruitment's done in 6 months and not 2 years? So my key message for all of you is please go and learn about this. If you're a study coordinator, it's really, really important. And this model will bring the equity and access that all rural, regional and remote people need, including all First Nations in Australia and New Zealand. So I'll finish there. Thank you.